So, management of epilepsy. First of all, I'm just going to do a brief introduction into epilepsy and the different types of seizures that there are, management of seizures, and talk about anti-seizure medication. So what is epilepsy? It's a sudden abnormal burst of intense electric activity in the brain, and this activity disrupts normal neuronal functioning. And a seizure is a manifestation of this abnormal activity and can take many forms dependent upon the area of the brain that's affected. So the types of seizures. Seizures may affect the whole brain from the onset. These are called generalised seizures. Seizures may be confined to one area of the brain, and these are called partial or focal seizures. And then partial seizures may spread to the whole brain, and these are called secondary generalised seizures. So generalised seizures affect the whole brain, and within this category we see tonic-clonic, stiffening and jerking, and that's what we traditionally think of as a seizure. We may have tonic seizure, which is just stiffening, atonic, also known as drop attacks, myoclonic, which are muscle jerks, absent seizures, and all these are associated with a level of loss of consciousness. Partial seizures, these are these are seizures that only affect a part of the brain. So we've got simple partial. Consciousness isn't impaired, many different presentations including jerking of a limb, tingling sensations, déjà vu, hallucinations, sensory, motor, autonomic or psychic. Or complex partial. Consciousness is impaired, can be associated with autonomisms such as lip smacking, fiddling with objects, walking around, sort of a bit muddled, dyscognitive. For these seizures, I think it's important to note that sometimes patients, or sometimes we're not always aware this is seizure activity. A lot of people think of seizure activity as the more generalised seizures, but a lot of patients have what I call minor seizure activity, and I think it's important for us to try and pick these up, be aware and try and pick these up, because sometimes someone may have some minor activity, which is almost like a warning signal, and then will develop into a more generalised seizure. So management of seizures, I'm going to talk about medication, but I also want to mention other really important areas that we can help manage. Anxiety. So give patients reassurance and psychological support. Safety. Offer guidance and epilepsy information booklets. Catherine has mentioned it before. She gave a lovely slide. I've just given you a link there. The epilepsy website, you can't order information books. You have to pay to join it. But what you can do is print off the PDFs, and you can give those to your patients. And patients will eat up any information you can give them, patients and relatives, the family, because it's a very scary time. Quality of life. Someone's diagnosed with seizures or had a seizure, it's very scary. Family member has witnessed a seizure, it's very scary. Someone gets diagnosed with the brain met, and the first thing that happens, they can be very well, as we've touched before, they lose the driving licence. There's an element of losing their independence. Someone's had a seizure, people are scared to leave them on their own, they're scared to be left on their own, so that affects their level of independence as well, and also the loss of control. So what we can do to try and help that is encourage them to take part in their management, encourage them to keep a seizure diary, encourage them to feed back to us regularly, and be aware of what their seizure triggers are. Now, common seizure triggers are increased fatigue. Some swelling may be a seizure trigger. Treatment may be a seizure trigger. We've talked about radionecrosis. When someone's going through treatment, they may have some seizure activity. But seizures aren't always related to swelling. Seizures can happen at any time for no reason. Once someone's had 1 or 2 seizures, they can have seizures at any time. And it doesn't always relate to activity within the brain tumour. And obviously, people do not like being told they've got epilepsy. They're more likely to say, I don't have epilepsy, I just have seizures. They're happy to say they've got a brain met or whatever the disease, but they don't like being categorised and having that stigma. So looking at anti-epileptic medication, review your local guidelines. I'm not sure where everyone's from today, which the local area. But we at the Christie have got clinical guidance document. That's available on our intranet at the moment. It will be available on the Manchester Cancer website within a couple of weeks. It's just been checked and it's got to that time to go on there. But if anybody wants to see a copy of that, obviously Christie staff here can access it, but we can keep a copy, add a copy of the guidelines with the actual presentations that will be emailed out. So what you're doing is you're looking at your choice of your anti-epilepsy drugs. And when you're choosing the drugs, there's different factors you need to think of. Consider the patient's general health. Consider what treatment they're on. And look at the side effects of each of the drugs that you're having. All of these drugs can produce degrees of sedation, tiredness and mental slowing. But some drugs have other individual side effects that you may need to think about when you're considering what other treatment these patients are having. So anti-epileptic medication has been around a long time, some of it, 1912. Before 2000, a lot of these drugs, there are some drugs that we still use, but a lot of these older drugs, what we call more dirty drugs, they may have more side effects. And after 2000, these newer drugs that are coming through can have less side effects, but as I say, all can have side effects. So it very much depends on the individual patient. So you look at a side effect, say Keppra, which is very commonly used, levetiracetam. When you start that drug, it can make people feel very tired. Is that something you want to give someone who's older, who's already got other issues and comorbidities, and is that going to be the best for them? Or would they give them something else like sodium valproate or Epilim as we know it? So there's lots of choices that can be made. So what you'd do, you'd start with an initial monotherapy. So the most gentle way or kindest way is to start on a low dose and titrate quite low. And the slower you titrate, the less the symptoms, the more gentle it is. So say if we were starting on Keppra, you would look to titrate and increase every 2 weeks till you're at a therapeutic dose. While you're doing this, you're assessing for seizure activity. And you're assessing and monitoring closely and encouraging the patient to let you know if they're getting any signs or symptoms. If everything's fine and there's no more seizures, which for some patients who have a seizure at diagnosis, they won't have any more, but around 40% or more will have further seizure activity. If they're fine, you keep it at that dose and that's fine. If you notice someone's got a lot of toxicity and they're not tolerating the treatment, you'd look at maybe altering it to another anti-seizure medication. But instead of stopping and starting one, what you'd do is you'd introduce the second and titrate that up whilst titrating the other one down before stopping. So as you see the different potential side effects that you can get, these are some of the most common side effects that we see. Obviously, we're not only looking at side effects, we're looking at the effectiveness of the medication. So if someone's not having seizure control, again, same principle and just reduce gradually. We can always, if you've got someone who's struggling to get control of the seizures, you can refer to your local neurology team if necessary. And we can also look at using short-term additional medication, such as clobazam, which I know Dr. McBain had mentioned earlier. That's a quick-acting, useful as a short-term measure for cluster seizures or whilst other medication is being titrated. And I think, just to say with that, you've had someone who maybe have had seizures for 2 years but it's been very well controlled, suddenly may develop seizure activity. They've been investigated, there's no sign of any swelling. Steroids can be used as a treatment for seizures, but do not necessarily have to be. It's not necessarily a standard treatment. You would only use steroids if there's evidence of swelling. So you would look at increasing your medication, so you're titrating it, and whilst you're doing that, we'd look at prescribing clobazam 10 milligrams, and initially what we'd do is prescribe it 10 milligrams knock day for 2 weeks while the other medication is being titrated, but also informing the patients that if they do have some seizure activity, then what they can do is, if they, like Dr. McBain mentioned before, they feel they're about to have some seizure activity, they can take one then as well. Palliative care, end of life. I have to admit this is not my area of speciality, being hospital based, but I do liaise a lot with the community, and what I see is different areas have different standard medication regimes, but predominantly we have IM midazolam, buccal midazolam as we've discussed before, IV lorazepam, and IV diazepam is still used in some areas. And just of note, both the sodium valproate and Keppra are both available in IV preparations and can be used. Finally, it's all about teamwork. To get effective management of seizures, you need to be involving the patients, the clinicians, and that includes the doctors, the nurses and the community teams, AHPs, all working together to try and get this under control. Thank you.